Block simulation 19. Same process, fresh set, read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. What is the underlying mechanism? A 5-year-old boy develops scattered petechiae and bruising and a few nosebleeds about 2 weeks after a viral upper respiratory infection. He is otherwise well. Labs, isolated thrombocytopenia. Platelets 22,000 with normal hemoglobin, white count, PT, and PTT. Peripheral smear shows few but large platelets. Read the command. Underlying mechanism. Child, post-viral, isolated thrombocytopenia with large platelets, normal everything else. Immune thrombocytopenic purpura, antiplatelet antibodies. This is immune thrombocytopenic purpura, ITP. The mechanism is autoimmune. The body produces autoantibodies, classically IgG, against the platelet glycoprotein GPI-IBOI-II. These antibody-coated platelets are recognized and destroyed by macrophages in the spleen. The result is an isolated thrombocytopenia. Only the platelet count is low, with normal hemoglobin, white count, and normal coagulation times, PT and PTT, because this is a pure platelet problem, not a clotting cascade or marrow problem. The marrow compensates by releasing young, large platelets. The correct answer is C. In children, ITP is typically acute and follows a viral infection, and it is often self-limited. In adults, it tends to be chronic. The isolated thrombocytopenia with normal PT-PT distinguishes it from DIC, which prolongs PT-PTT and lowers fibrinogen, and from TTP, which has schistocytes and a microangiopathic anemia. Treatment, if needed, is corticosteroids, IVIG, and for refractory cases, splenectomy. Antiplatelet antibodies causing splenic destruction with isolated thrombocytopenia is ITP. Which relationship governs mean arterial pressure, and why does it fall in septic shock? A physiologist models systemic hemodynamics. A patient develops septic shock in which systemic vascular resistance falls dramatically. Despite a compensatory increase in cardiac output, mean arterial pressure drops. Read the command, which relationship governs MAP and why it falls. MAP, COT, TPR, falling resistance lowers MAP in septic shock. Mean arterial pressure is governed by an analog of Ohm's law. MAP equals cardiac output times total peripheral resistance. MAP chemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechechemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemochemoche barriers cause massive vasodilation, so total peripheral resistance falls dramatically. Even though the body compensates with an increased cardiac output, the warm, hyperdynamic shock, the drop in resistance is so large that the product and thus the MAP still falls, causing hypotension. The correct answer is E. This single relationship explains blood pressure regulation and shock states. You can also express MAP as diastolic pressure plus 1/3 of the pulse pressure. In distributive septic neurogenic anaphylactic shock, the primary problem is low resistance. In cardiogenic and hypovolemic shock, the primary problem is low W cardiac output with compensatory high resistance. MAP equals cardiac output times total peripheral resistance, with the resistance collapse explaining the hypotension of septic shock. A deficiency of which trace element best explains these findings. A patient on long-term total parenteral nutrition, TPN, without adequate trace element, supplementation develops a scaly erythematous rash around the mouth, eyes, and anus. Acrodermatitis, hair loss, poor wound healing, impaired taste, and recurrent infections. Read the command. Which trace element? TPN, periorificial rash, alopecia, poor wound healing, impaired taste. Zinc deficiency. This is zinc deficiency. Zinc is a cofactor for hundreds of enzymes, including many involved in DNA synthesis, wound healing, immune function, and the sense of taste and smell. Deficiency seen with inadequate intake, malabsorption, long-term TPN without supplementation, or the inherited disorder acrodermatitis enteropathica produces a characteristic constellation, a scaly erythematous rash in a periorificial and acral distribution around the mouth, eyes, anus, and on the extremities, alopecia, poor wound healing, impaired taste of dysgeusia and smell, recurrent infections from impaired dysgeusia and smell, recurrent infections from impaired immunity, and in children growth retardation and hypogonadism. The correct answer is C. The classic triad to recognize is the periorificial dermatitis, alopecia, and impaired wound healing, often with taste disturbance, and the high-risk setting of TPN or malabsorption. The inherited form, acrodermatitis enteropathica, is due to defective zinc absorption. The combination of the periorificial rash, hair loss, or healing, and dysgeusia points specifically to zinc deficiency, which is corrected with supplementation. Which bone is most likely fractured, and what is the feared complication? A 22-year-old man falls onto an outstretched hand. He now has pain and tenderness in the anatomical snuff box at the base of the thumb. Initial x-rays are normal, but he's placed in a thumb spica cast due to suspicion of a specific fracture. Read the command, which bone and feared complication? Fall on outstretched hand, anatomical snuff box tenderness, scaphoid fracture, a vascular necrosis. This is a scaphoid fracture, the most commonly fractured carpal bone, typically from a fall onto an outstretched hand, push. The hallmark sign is tenderness in the anatomical snuff box, the hollow at the base of the thumb bounded by the extensor tendons. The feared complication is a vascular necrosis of the scaphoid. This is because of its peculiar blood supply. The scaphoid is supplied in a retrograde fashion. Blood enters at the distal pole and flows back toward the proximal pole. So a fracture through the middle, the waist, can cut off blood to the proximal fragment, causing it to die. The correct answer is A. A critical clinical point. Scaphoid fractures are often not visible on initial x-rays, so a patient with snuff box tenderness after a fouche is treated empirically with a thumb spica cast and re-imaged in 1 to 2 weeks, or with MRI to avoid missing it and risking non-union and a vascular necrosis. The snuff box tenderness after a fall on an outstretched hand, with the risk of a vascular necrosis from the retrograde blood supply, identifies a scaphoid fracture. What does this CSF profile indicate, and how does it differ from viral meningitis? A 19-year-old presents with fever, headache, neck stiffness, and photophobia. A lumbar puncture is performed. The CSF shows opening pressure elevated, neutrophil predominant pleocytosis cells in the thousands, low glucose, and Hic protein. Read the command, what the CSF indicates and the difference from viral. Neutrophils, low glucose, high protein, bacterial meningitis versus viral lymphocytes, normal glucose. This CSF profile indicates bacterial meningitis. The classic bacterial pattern is a neutrophil predominant pleocytosis, often thousands of cells, a markedly loud CSF glucose, because bacteria and inflammatory cells consume glucose, and a H protein with elevated opening pressure. The clinical picture of fever, headache, neck stiffness, and photophobia fits meningitis, and these CSF findings point specifically to a bacterial cause requiring urgent antibiotics. The correct answer is B. Memorize the CSF patterns by cause. Bacterial, neutrophils, low glucose, high protein. Viral, lymphocytes, normal glucose, normal to mildly high protein. Fungal, LDB, lymphocytes, LOW glucose, high protein, yet slower, more indolent course. The glucose and cell type are the key discriminators. Low glucose with neutrophils means bacterial. Normal glucose with neutrophils means bacterial. Normal glucose with neutrophils means bacterial. Normal glucose, nortrove not to mildly high protein. EFUI-CTD, ESF patterns. The neutrophilic low glucose high protein CSF indicates bacterial meningitis. Which pairing of cell, hormone, and function is correct? A physiologist studies the male reproductive axis. Two cell types in the testis respond to two different pituitary hormones. Read the command. Which pairing is correct? Leydig LH, LH, testosterone, Sertoli, FSH, FSH, spermatogenesis support, inhibin. The testis has two key cell types with distinct hormonal control. Leydig cells in the interstitium respond to LH luteinizing hormone and produce testosterone. Sertoli cells lining the seminiferous tubules respond to FSH follicle, stimulating hormone and subortiz spermatogenesis. They nourish developing sperm, form the blood-testis barrier, and secrete I-inhibin B and androgen binding. Proteinesis, they nourish developing spermia and secrete I-inhibin binding protein. A useful mnemonic, LH acts on Leydig and FSH acts on Sertoli, which supports sperm. The correct answer is D. The feedback loops are testable. Testosterone provides negative feedback on LH and NNNNNC, while I-inhibin from Sertoli cells provides selective negative feedback on FSH. This is why, in primary testicular failure, FSH and LH rise, and inhibin falls. The LH-Leydig testosterone and FSH-Sertoli spermatogenesis pairings, with Sertoli cells producing inhibin, are the correct relay cells producing inhibin, are the correct relationships. What is the drug and its mechanism, and a key contraindication? A patient with acutely elevated intracranial pressure from cerebral edema is given an intravenous agent that is freely filtered at the glomerulus, but not reabsorbed, drawing water out of cells and tissues into the vascular and tubular compartments. Read the command drug mechanism contraindication. Osmotic agent for raised ICP, freely filtered not reabsorbed, mannitol, contraindicated in anuria heart failure. The drug is mannitol, an osmotic diuretic. It is freely filtered at the glomerulus, but not reabsorbed by the tubules, so it remains in the tubular fluid and raises its osmolarity, holding water in the tubule and producing a diuresis. Mannitol also raises plasma osmolarity, which osmotically draws water, OUT, of cells and tissues, including the brain, into the vascular compartment. This is why it is used to reduce raised intracranial pressure from cerebral edema and to lower intraocular pressure. The correct answer is E. The key contraindications follow from its mechanism. In anuria, EAG, from acute tubular necrosis, mannitol cannot be excreted and accumulates, worsening fluid overload. And in heart failure, the initial expansion of intravascular volume, as mannitol pulls water into the bloodstream before diuresis, can precipitate pulmonary edema. So, mannitol is avoided in anuria and in heart failure. The osmotic diuretic that is filtered but not reabsorbed, pulling water out for raised ICP, contraindicated in anuria and heart failure, is mannitol. What is this oncologic emergency, the mechanism, and a key preventive drug? A patient with a bulky Burkitt lymphoma is started on chemotherapy. Within 1 to 2 days, he develops acute kidney injury, and labs show HIGH potassium, HIGH phosphate, HIGH acid, and low calcium. Read the command, emergency, mechanism, preventive drug. Post-chemo, AKI, high K-phosphatouric acid, low calcium, tumor lysis syndrome, prevented with hydration and allopurinol rasburicase. This is tumor lysis syndrome, an oncologic emergency. It occurs when a large, rapidly dividing tumor like Burkitt lymphoma or acute leukemia undergoes massive cell lysis, usually shortly after starting chemotherapy. The dying cells dump their intracellular contents into the blood, potassium, hyperkalemia, risking arrhythmia, phosphate, hyperphosphatemia, and nucleic acids that are metabolized to uric ACIC, hyperuricemia. The high phosphate binds calcium, causing hypocalcemia. The uric acid and calcium phosphate precipitate in the renal tubules, causing acute kidney injury. The correct answer is B. The metabolic signature to memorize is the 4 changes: high potassium, high phosphate, high uric acid, and low calcium, with acute kidney injury. Prevention and Treatment Center on Aggressive IV. Hydration plus lowering uric acid. Allopurinol, a xanthine oxidase inhibitor. that prevents uric acid formation before chemotherapy, or rasburicase, which enzymatically breaks down existing uric acid for high-risk or established cases. The massive cell lysis metabolic derangement with AKI, prevented by hydration, and allopurinol or rasburicase is tumor lysis syndrome. What is the organism, and how does its toxin contribute to disease? An unvaccinated infant presents with severe paroxysms of coughing followed by a sharp inspiratory whoop and post-tussive vomiting. Between coughing fits, he appears well. CBC shows a marked LYM, phagocytosis. Culture on Bordet, Gengu or Regan. Read the command, organism, and how toxin contributes. Whooping cough, lymphocytosis, gram-negative Coccobacillus on Bordet, Gengu. Bordetella pertussis. Pertussis toxin disinhibits adenylate cyclase. Whooping. This is whooping cough caused by Bordetella pertussis, a small gram-negative Coccobacillus grown on Bordet, Gengu, or Regan, lowi media. The disease has 3 stages: a Caterhauer stage, mild, cold-like; a paroxysmal stage, the severe coughing fits with the inspiratory whoop and post-tussive vomiting; and a convalescent stage. Pertussis toxin is a key virulence factor. It ADP ribosylates the inhibitory G protein G, inactivating it. Because G normally restrains adenylate cyclase, disabling it leaves adenylate cyclase disinhibitide, raising cyclic AMP. This contributes to the characteristic marked LY lymphocytosis, impaired lymphocyte trafficking, and other effects. The correct answer is D. The mechanistic contrast worth knowing: cholera toxin permanently activates the stimulatory Gs to raise CAMP, while pertussis toxin inactivates the inhibitory G to raise CAMP. Both increase CAMP, but at opposite ends of the G protein switch. The whooping cough with lymphocytosis grown on Bordet Gengu, with pertussis toxin disinhibiting adenylate cyclase via G, identifies Bordetella pertussis. Prevent with the DTaP vaccine. Where does isotonic saline distribute, and how does it differ from infusing free water hypotonic or 3% hypertonic saline? A patient receives a rapid infusion of isotonic 0.9% normal saline. A physiologist analyzes how this fluid distributes among the body fluid compartments. Read the command, where isotonic saline distributes and how it differs. Isotonic stays extracellular. Free water enters all compartments. Hypertonic pulls water out of cells. Body fluid is divided into the intracellular ICF and extracellular ECF compartments, separated by cell membranes that water crosses freely but sodium does not. Isotonic saline 0.9% has the same osmolarity as plasma, so it does not create an osmotic gradient across cell membranes. It stays in the extracellular compartment, expanding the plasma and interstitial volumes without entering cells. This makes it ideal for resuscitating intravascular volume. The correct answer is C. Contrast the other fluids. Free, water or hypotonic fluid like D5W after the glucose is metabolized dilutes the ECF, lowering its osmolarity, so water shifts ion to cells, distributing across ALL compartments and even swelling cells. Hypertonic saline 3% raises ECF osmolarity, drawing water out of cells into the ECF, used to treat cerebral edema and severe hyponatremia. So isotonic stays extracellular, free water goes everywhere including into cells, and hypertonic pulls water out of cells. What is the diagnosis and mechanism? A 48-year-old man with a strong family history of colon cancer, father and grandfather, both diagnosed in their 40s, develops a right-sided colon adenocarcinoma. There are no hundreds of polyps. Tumor testing shows microsatellite instability and loss of a DNA mismatch repair protein, mismatch repair. Read the command, diagnosis and mechanism. Family history, right-sided colon cancer, no polyposis, microsatellite instability, mismatch repair loss. Lynch syndrome, HNPCC. This is Lynch syndrome, hereditary non-polyposis colorectal cancer, HNPCC. It is an autosomal dominant condition caused by a germline mutation in one of the DNA mismatch repair genes, such as MLH1 or MSH2. When the mismatch repair system fails, errors in repetitive DNA sequences accumulate, producing microsatellite instability, the molecular hallmark. This drives early onset colorectal cancer, characteristically on the right side of the colon, without the thousands of polyps seen in familial adenomatous polyposis, hence non-polyposis. The correct answer is B. The contrast are high yield. Lynch syndrome, HNPCC, is the mismatch repair MSI pathway. Few or no polyps, right-sided, early onset, and associated with endometrial, ovarian, and other cancers. Familial adenomatous polyposis FAP is the APC mutation pathway, hundreds to thousands of colonic polyps with near 100% cancer risk. And sporadic colon cancer follows the APC KRAS. Pollen cancer follows the APC KRAS. The mismatch repair defect with microsatellite instability, right-sided cancer, and no polyposis identifies Lynch syndrome. Where is the lesion in the visual pathway? A 60-year-old man has a stroke. On visual field testing, he has a complete loss of the right half of the visual field in BOH eyes, right homonymous hemianopia, with no other visual deficit. Read the command where the lesion is. Right homonymous hemianopia. Lesion of the left optic tract or radiations cortex behind the chiasm. A homonymous hemianopia, loss of the same half of the visual field in both eyes, localizes the lesion to the visual pathway behind the optic chiasm on the side opposite the field loss. Here, loss of the right visual field in both eyes means the lesion is on the LEFT side, in the left optic tract, optic radiations, or occipital visual cortex. The reason, after the chiasm, the left-sided pathway carries information from the right half of the visual world from both eyes, so damaging it knocks out the right field bilaterally. The correct answer is D. Map the visual pathway lesions. A lesion of only optic nerve before the chiasm causes monocular blindness in that eye. A lesion at the optic chiasm, e.g. pituitary tumor, causes bitemporal hemianopia loss of both peripheral fields from the crossing nasal fibers, and a lesion behind the chiasm, optic tract, radiations, or cortex causes a contralateral homonymous hemianopia. The right homonymous hemianopia localizes to a left retrochiasmal lesion. What is the physician's obligation or the principle established in the Tarasov case? During a psychiatric evaluation, a patient makes a specific credible threat to seriously harm a named, identifiable third person. The physician must decide how to handle confidentiality. Read the command. Physician's obligation per Tarasov. Credible threat to identifiable third party. Duty to protect. Warn overrides confidentiality. This invokes the Tarasov principle, the duty to protect or warn. While patient confidentiality is a cornerstone of medical ethics, it is not absolute. When a patient makes a specific, credible threat of serious harm against an identifiable third person, the physician's duty to protect that potential victim overrides confidentiality. The physician should take reasonable steps to protect the intended victim, which may include warning the identifiable person directly, notifying the police, or hospitalizing the patient. The correct answer is E. This is one of the recognized exceptions to confidentiality. The others include reportable communicable diseases, suspected child or elder abuse, certain impairments, e.g., a seizure-prone driver, and a patient who is an imminent danger to self or others. The common thread is preventing serious harm. The credible, specific threat against an identifiable victim, triggering the duty to protect, which overrides confidentiality, is the Tarasov obligation. Which glycogen storage disease is this? A 4-month-old infant presents with progressive muscle weakness, a floppy hypotonic appearance, difficulty feeding, an enlarged tongue, and, most strikingly, massive cardiomegaly with hypertrophic cardiomyopathy. Glycogen accumulates in lysosomes. Enzyme assay shows deficient acid alpha-glucosidase, I-acid maltase. Read the command, which glycogen stores disease. Infant, floppy, cardiomegaly, lysosomal glycogen, acid maltase deficiency, Pompe disease, type 2. This is Pompe disease, glycogen storage disease type 2, caused by a deficiency of ACID, alpha-glucosidase, also called acid maltase. This is a lysosomal enzyme that degrades glycogen within lysosomes. When it is deficient, glycogen accumulates inside lysosomes throughout the body, particularly damaging cardiac and skeletal muscle. The infantile form presents in the first months of life with a floppy, hypotonic baby, feeding difficulty, macroglossia, enlarged tongue, and the striking hallmark, massive cardiomegaly with hypertrophic cardiomyopathy, often leading to early heart failure and death without enzyme replacement. The correct answer is B. The memory hook is Pompe trashes the pump heart. The cardiomegaly is the distinguishing feature. Pompe is unusual among glycogen storage diseases in being a lysosomal disorder. The glycogen accumulates in lysosomes, and unlike von Gierke and McArdle, it does not cause fasting hypoglycemia because cytoplasmic glucose metabolism is intact. The lysosomal acid maltase deficiency with massive cardiomegaly and hypotonia in an infant is Pompe disease. What is the diagnosis, the inheritance, and a feared external complication? A 45-year-old man presents with bilateral flank pain, hematuria, and hypertension. Exam reveals large palpable kidneys bilaterally. Family history: his father had kidney failure and died of a brain bleed. Ultrasound shows numerous bilateral renal cysts, and he also has hepatic cysts. Read the command, diagnosis, inheritance, feared complication. Adult, bilateral renal cyst, hypertension, hepatic cyst, family history of kidney failure and brain bleed, ADPKD, berry aneurysm rupture. This is autosomal dominant polycystic kidney disease. ADPKD, the most common inherited kidney disease, usually presenting in adulthood. It is caused by mutations in PKD1, chromosome 16, most common and more severe, or PKD2. Numerous fluid-filled cysts progressively replace both kidneys, causing flank pain, hematuria, hypertension from renin activation, palpably enlarged kidneys, and eventual end-stage renal disease. Extrarenal manifestations include hepatic cysts and, importantly, intracranial barisaccular aneurysms. The correct answer is C. The feared external complication highlighted by the family history of a fatal brain bleed is rupture of a berry aneurysm, causing a subarachnoid hemorrhage. ADPKD is also associated with mitral valve prolapse and colonic diverticula. Contrast with the autosomal recessive form RPKD, which presents in infancy with enlarged kidneys and is associated with congenital hepatic fibrosis and Potter sequence. The autosomal dominant bilateral renal cysts with hepatic cysts and berry aneurysm risk identify ADPKD. Which type of shock is this, and how does it differ hemodynamically from hypovolemic shock? A patient in the ICU has a pulmonary artery catheter. He is hypotensive. Readings: cardiac output is high, systemic vascular resistance is low, and the pulmonary capillary wedge pressure, preload, is low to normal. His extremities are warm. Read the command with shock and difference from hypovolemic. High CO, low SVR, warm, distributive septic shock versus hypovolemic, low CO, high SVR, cold. This is distributive shock, classically SE-peptic shock. The hemodynamic signature is a H cardiac output, a markedly low systemic vascular resistance from inflammatory vasodilation, and warm, well-perfused extremities, the warm shock. The low SVR is the primary problem, and the heart compensates by increasing output. The wedge pressure, a measure of preload left atrial filling, is low to normal. The correct answer is D. Contrast the shock profiles, which are heavily tested. Hypovolemic and cardiogenic shock both have low cardiac output with compensatory HIH, SVR, and cold, clamped extremities. But cardiogenic has a hitch wedge pressure, the failing heart backs up, while hypovolemic has a low wedge pressure, empty tank. Distributive, septic, anaphylactic, neurogenic shock is the odd one out. Hitch cardiac output, loud SVR, warm extremities. The high output, low resistance, warm picture is distributive shock, opposite the cold, low output, high resistance, hypovolemic profile. What is the underlying pathophysiology? A 30-year-old man presents with well-demarcated erythematous plaques covered by silvery, white scales on his extensor elbows, knees, and scalp. When the scale is scraped off, pinpoint bleeding appears, Auspitz sign. He also has pitting of the nails. Biopsy shows epidermal hyperplasia, acanthosis, retained nuclei in the stratum corneum, parakeratosis, and neutrophils in the epidermis, Monroe microabscesses. Read the command underlying pathophysiology. Silvery plaques on extensors, Auspitz sign, nail pitting, parakeratosis, Monroe microabscesses, psoriasis, keratinocyte, hyperproliferation. This is psoriasis, a chronic immune-mediated inflammatory skin disease. The underlying pathophysiology is hyperproliferation of ferroliferacy of keratinocytes with a dramatically increased epidermal turnover rate driven by an abnormal T-cell Th17T20 immune response with cytokines like TNF and IL-170. Because the keratinocytes proliferate too fast, the epidermis thickens asymptosis, and the cells reach the surface without maturing, retaining their nuclei in the stratum corneum, parakeratosis, forming the thick silvery scale. Neutrophils collect in the epidermis as Monroe microabscesses. The correct answer is E. The clinical clues are classic, well-demarcated silvery plaques on the E extensor surfaces. Elbows, knees, and scalp. The Auspitz sign, pinpoint bleeding when scale is removed. From the thin suprapapillary epidermis over dilated capillaries, nail pitting, and the Kebner phenomenon, lesions at sites of trauma. Psoriasis is associated with psoriatic arthritis, the immune-mediated keratinocyte hyperproliferation with rapid epidermal turnover, parakeratosis, and Monroe microabscesses define psoriasis. What is the mechanism, and how does leucovorin folinic acid affect its action? A patient with colon cancer is treated with 5-fluorouracil 5-FU. The drug is a pyrimidine analog that, after activation, inhibits an enzyme essential for DNA synthesis. Read the command, mechanism, and leucovorin's effect. 5-FU inhibits thymidylate synthase. Leucovorin enhances, stabilizes the complex. 5-fluorouracil is a pyrimidine antimetabolite. After activation, its metabolite 5-50-imidylate inhibits thymidylate synthase, the enzyme that converts DUMP to DTMP, thymidine monophosphate. DTMP is essential for DNA synthesis, so blocking thymidylate synthase causes thymineless death of rapidly dividing cells. The key twist about leucovorin folinic acid, unlike with meatless dividing cells, the key twist about leucovorin folinic acids, nucovertump to DTMP thymidine monophosphate. It increases the cellular pool of the reduced folate N5 and then methylene, THF, that is required to form the stable inhibitory complex of 5-FDUP with thymidylate synthase, so it stabilizes and strengthens the inhibition. The correct answer is A. This is a classic point of confusion worth nailing. With methotrexate, a DHFR inhibitor, leucovorin rescues normal cells from toxicity. But with 5-FU, leucovorin enhances the cytotoxic effect by reinforcing the thymidylate synthase inhibition, so they are co-administered to improve efficacy in colorectal cancer. The thymidylate synthase inhibition with leucovorin enhancing, not rescuing, is 5-FU's mechanism. Which virus is this? And what is its key feature explaining the high chronicity and lack of vaccine? A 50-year-old man with a history of IV drug use is found to have abnormal liver enzymes. Testing reveals a positive antibody and a detectable RNA viral load for a virus. He is largely asymptomatic but is at high risk of progressing to chronic infection, cirrhosis, and hepatocellular carcinoma. There is no vaccine. Read the command, which virus and key feature. IV drug use, RNA virus, high chronicity, no vaccine, hepatitis C, high genetic variability. This is hepatitis C, an RNA virus, a flavivirus transmitted primarily through blood, classically via IV drug USE. Its defining feature is a very HIEH rate of progression to chronic infection. The majority of acutely infected people fail to clear it, leading over years to cirrhosis and a markedly increased risk of hepatocellular carcinoma. Most acute infections are asymptomatic, which is why it is often detected incidentally. The correct answer is A. The key feature explaining both the high chronicity and the LACK of a vaccine is the virus's high genetic variability. Hepatitis C has an error-prone RNA polymerase and exists as many genotypes and rapidly mutating quasi-species, so it constantly changes its surface antigens to evade the immune response, defeating both natural clearance and vaccine development. Unlike hepatitis B DNA virus, vaccine available, there is no HCV vaccine. The RNA virus with high genetic variability, high chronicity, IV drug transmission, and no vaccine is hepatitis C. Modern direct-acting antivirals can cure it. What is this group of disorders and the definitive treatment? A male infant presents with severe recurrent infections from birth, bacterial, viral, and fungal, including pneumocystis and chronic candidiasis, and failure to thrive. Labs show profoundly LOW lymphocytes with absent T cells and absent or non-functional B cell responses. He has no thymic shadow. One cause is adenosine deaminase, ADA, deficiency. Read the command, which group in definitive treatment? Infant, infections of all types, absent T cells, ADA deficiency, severe combined immunodeficiency, treated with stem cell transplant. This is severe combined immunodeficiency, CD. It is a group of disorders characterized by a profound defect in both cellular, T cell, and humoral B cell immunity, so affected infants suffer severe, recurrent infections of ALL types from birth, bacterial, viral, and fungal, including opportunistic organisms like pneumocystis and candida, with failure to thrive and an absent thymic shadow. Causes include adenosine deaminase, ADA, deficiency, a toxic metabolite kills lymphocytes, and X-linked mutations in the IL-2 receptor gamma chain, defective cytokine signaling for lymphocyte development. The correct answer is A. This is the bubble boy disease, historically requiring strict isolation. The two classic causes to remember are ADA deficiency and the X-linked IL-2 receptor gamma chain defect. Live vaccines are contraindicated. The organism can disseminate. The definitive treatment is a hematopoietic stem cell, bone marrow, transplant to restore a functioning immune system, with gene therapy emerging for some forms. The absent T and B cell immunity from birth, including ADA deficiency, treated with stem cell transplant, is DID. Block 19 is done. Let's review the 5 biggest traps from this block. Trap 1. Immune thrombocytopenic purpura is an isolated low platelet count with normal coagulation times caused by antiplatelet antibodies and splenic destruction. Normal PT and PTT separated from DIC. Trap 2. A fall on an outstretched hand with snuffbox tenderness is a scaphoid fracture until proven otherwise. It is often invisible on early X-rays, so cast empirically. The retrograde blood supply risks a vascular necrosis. Trap 3. Tumor lysis syndrome. After chemotherapy of a high turnover tumor releases potassium, phosphate, and uric acid, lowering calcium and causing acute kidney injury. Prevent with hydration, allopurinol, or rasburicase. Trap 4. Lynch syndrome is a mismatch repair defect with microsatellite instability, few polyps, and right-sided early cancer. Familial adenomatous polyposis is an APC mutation with thousands of polyps. Trap 5. Leucovorin enhances 5-fluorouracil by stabilizing its inhibition of thymidylase synthase, but rescues normal cells from methotrexate toxicity. Same drug, opposite roles. 19 blocks. 380 questions. Train process, not memorization. StepLogic. Learn how to think, not memorize.